Hi, this is Dr. Artie Kavanaugh coming to you from the American College of Rheumatology 2017 meeting for Rheum Now. Today's the last day of the meeting, Wednesday, November 8th, and as we've done for actually quite a few years now, my friend and colleague Dr. Jack Cush and I did our Rheumatology Roundup, in which we just take a wild tour of some of the more interesting abstracts, usually posters, that we saw at this year's meeting. So here's a few that I reviewed, which I think were really good abstracts. One is abstract 661, which was from the group in Leeds. Dennis McGonigal and his fellow Dr. Cuthbert presented this, and this looked at gamma delta cells in bone, in the entheses that's just about bone from spinal samples. These were patients who were undergoing surgery, and they just took the spinal samples and they saw that it was enriched for gamma delta cells. The reason this is important is it actually gives first demonstration in humans that you do find gamma delta cells in enthesial locations. Now, these were not patients with inflammatory arthritis, but I think this is a natural step. Gamma delta cells can make IL-23. We know that cytokine can be important. I think we look forward to more development on this to teach us maybe how best to approach patients who have certain conditions associated with enthesitis, particularly psoriatic arthritis and the other spondyloarthropathies. Another poster that I really liked was number 1112. Small study, but what it showed was patients who go to the emergency room for a gout flare, they're treated with all different regimens of steroids. So this looked at high dose, 60, 50, 40, 30, 20, 10, and then stopping, or low dose, half that, 30, 25, 20, 15, 10, 5, and then stopping. Turns out that not only do you not need the higher dose, but the people actually did better in terms of getting back to the pre-treatment pain level. They did better with the moderate dose, as it was called. So all of us use steroids a little bit different, and I think we all like information that can tell us how to perhaps use them a little better. Another abstract, actually a couple of abstracts, 2031 and 2032, which are right next to each other. Junior faculty member who was questioned by some medical students and said their hypothesis was that patients who look at their labs in the electronic chart maybe do better. Remember, those people are more involved in their care, and I guess you could take that hypothesis. You could take the alternative that there are people who just look at their lab tests all the time, and what they looked at the SED rate, and it did not appear that those people who looked at the labs more often had a greater decrease in their SED rate than did those who did not look at the lab. So with all of us having to use electronic records more and more, I think it's nice to know what information can we get from the electronic medical record. And this certainly includes patient involvement. Patients ought to be involved in their health care and their health care decisions, and how best can we integrate them into that and get perhaps better disease control. So it was a nice poster by a young faculty member in rheumatology addressing an issue raised by the students. So really the kind of nice project that we like to see at the ACR meeting. So this is Dr. Artie Kavanaugh saying goodbye from the ACR 2017 in San Diego, and you'll hear much more on Rheum Now.